Let your curiosity rise.
Matrix webcast,
Where the human spirit flies. Matrix webcast. Where the human spirit flies.
Hey, welcome to the Medmix webcast. Let me turn off this. Welcome to the Medmix webcast. I have a formidable healthcare champion. He is a former CEO of Kaiser Permanente. Honored to have him. He's been on the podcast for a few times. Really, he's a well-informed. He knows one of the few, I would say, people who knows healthcare system in and out. In the top 5, I say he's one of them, definitely. So I learned a lot from him. His books and his talks and his podcast. It's a very informative. I all encourage you to listen to his podcast about the healthcare. So I come from a different background a little bit, physics background, and spend a lot of time in healthcare. So my angle is always different. I'm going to talk about that a little bit. And the thing is that our healthcare system is broken. There is no secret to it. Sorry, my co-host is Susan Davis, supposed to join, but she's traveling, and her tire is, it's something in the rain, in the Florida rain. So it's kind of going through a lot of stuff. I hope everything will be safe for her, and she's going to go home, reach, and she may join at the end. But anyway, in any case, let me, this is a wonderful discussion we're going to have. He's a former CEO for Kaiser Permanente. It's a huge organization, as people don't know in other countries, but Kaiser is a very big force here. He has a big health plan here in this country, in the United States, particularly West Coast and even Atlanta, where I'm from, Atlanta and all those places, very active, Kaiser Permanente. Okay, without further ado, let me introduce you one of the chief guests for me, Dr. Robert Pearl. She's an author, he's a Forbes contributor and a podcast host. Let me bring him to the table. Let me take this one out. Hello, sir. How are you? Welcome to the MedBix webcast.
I'm doing well, and it's always an honor and a privilege to be with you, having a good conversation about healthcare and hopefully educating the listeners.
Dr. Pearl, I was not thinking. I was always here. Anytime you can come to this podcast, but when I saw your podcast with the Mark Cuban, it is such an engaging conversation. It is eye-opening for all of us in that sense. What is going on behind the scenes of the healthcare systems? You really unravel everything into skeletal way. What are the problems in healthcare systems? So, I wanted to ask you, let us start with the just a step-by-step hierarchy kind of thing. I want to start with, we will go back to his main focus is, your conversation main focus is with the PBMs. That's a pharmacy benefit managers. So, but let us discuss other areas first, and then go back to the PBM's role, and then that's what I want to do. So let us talk about one of the first ones I want to talk about, drug manufacturers. As you know, drug manufacturers are, that is a big topic. But I remember, Dr. Pearl, the drug manufacturers, they are checking even the medical device manufacturers, checking what is the Medicare is paying. According to that, they're adjusting their price. So tell me, what that is not a therapeutic benefit, is basically directly relating to how much the market can tolerate. So tell us your perspective on that.
Well, let me start. When we talk about the drug industry, and you're talking now about the manufacturers, there's the distribution channels, there's the PBMs, and so on down the line. There are two ways you can compete. I teach at the Stanford Graduate School of Business as well as the medical school at Stanford. With the Graduate School of Business, we say you can compete by being the most effective and efficient, in which case you're competing on either price or cost of production, or you can do it by gaining market control. And every place I look inside the drug industry, it's all about market control. So you're starting right now with the manufacturers. What you see there is that they have figured out that because of the patent protection, you come up with a drug that people need, they don't have an alternative, it's their life. Whatever you charge, they're going to pay. And we have a legal system that gives them that kind of protection, whether they're getting care through Medicaid, through Medicare, through private insurance, it doesn't matter. And so that's what we see inside of that arena. The average price of a new drug, $300,000 this year. Impossible to justify, whether you look at the therapeutic value or you look at the cost of production. There's these days very little R&D because most of it is acquisition of other companies. And so that's what I see in terms of the manufacturers. They've taken, as you said, the price as high as they can take it, and each year it increases, which is really interesting. Because think about it, you don't have to put more R&D in. It's just purely profit year over year over year.
Yeah. So what about the generic drugs? So they become, after 20 years, the patent is gone. They become a generic drugs. So what they're doing is mirror formulation. They take that same drug, just a little bit of changes, and then say it's the original drug. And the government and all those people allow, because of lack of knowledge in the policymakers, or what is that missing there, sir? I mean, I'm lost in that area.
Well, one of the reasons is because the drug industry got Congress to prohibit the government from negotiating. Every other nation in the world, the government negotiates the cost of medications. The United States, it's illegal. Hard to imagine that occurred.
Yeah.
And so, so essentially, the government has to pay the retail price. So that's the challenge we have in our nation to start with. You're just starting in that particular arena, but it's a lot more than just that. It's the patent protection that, by the way, they got extended again. And I want listeners to understand there are two kinds of drugs, what's called small molecules and biologicals. Small molecules are what they sound like, just a small number of chemicals making it. A student in college or someone getting a master's degree could do it across a weekend. This is not hard to do. And these are the generics. And the generics now, basically, once they theoretically come on the market, the company prevents it by legal action. They sometimes buy a generic company in order to be able to avoid it. A lot of different ways that can happen. And then the biologicals, because they're such big molecules. We're talking about insulin, talking about drugs like that, massive molecules. You have to have what's called biosimilar. You have to have the same way of achieving the outcome. And you actually can't even patent those, but you can patent the process around it. And again, you have the same situation. The drug companies preventing new entrants coming in who would be selling drugs. And I think you've highlighted to your listening and viewing audience, insulin. This is a drug that should be very inexpensive. It's necessary to save a human life. And what do we find? We find parents having to give less doses than the doctor said because they can't afford to buy this life-saving drug on which the drug companies are making, as you noted, 1,000 or you said 15,000 times the profit compared to the cost of manufacturing.
You know, India became very good manufacturer of these drugs. There's somebody from Africa is telling me that, thank God to India, we are buying the vials of injection, for example, HPV vaccine or something, so cheap price, 10 cents. You know, when you import from the United States, it's just we can't afford it. So this is kind of a things. Why it is not even a free enterprise system. A free enterprise system is a non-negotiating principle in my view. Free enterprise system. they don't follow their own principles. What is thing that is missing there in the drug manufacturers? What I mean, I'm not trying to blame them. I'm trying to understand what their philosophy is. If they lose the world market to for generic drugs, but that's going to be biggest problem. They can manufacture themselves generic drugs and all those things, right? Yeah, and then make money.
Well, now you got to look at the economics. And first of all, a couple of years ago, I visited my friend Devi Shetty, a heart surgeon in Bangalore, and I got to visit one of the places manufacturing drugs. It was fascinating. It was a woman who actually got interested in beer, and she figured out she could use yeast fermentation to make insulin rather than as it's done in the United States with bacterial. But that's a whole different long story. 70% of the profits of drug companies come from the United States. 70%, despite the fact that our population is so much less. Why is that? We use a lot of drugs. We advertise, which is not done in most other countries, on TV. And most importantly, our prices are 3 to 4 times higher for the exact same medication. So you're right. And this is just not a competitive marketplace. Everything you learned in Economics 101 doesn't exist. This is a monopolistic marketplace. And so they don't really care. Most of the other countries can't afford what the drugs cost the United States, and they'll let someone else sell them for a small profit as long as they can keep their monopolistic control of the pharmaceutical world in the United States.
Dr. Pearl, I always listen to read your articles and everything. One thing you never miss is the solutions. So, what solution you have for these drug manufacturers? If there is solution, or wherever it is come from, either policymakers or from anywhere, what is the solution you have?
Unfortunately, in this arena, it's going to have to come through the government, because it's the laws that are protecting the drug companies and providing them with the monopolies, the opposite of what should be happening. If Congress reversed its prohibition at allowing the government to negotiate on behalf of all Americans, preferably, but even just Medicare and Medicaid, because usually they set the stage for the other prices, that would go a long way. And if they prohibited this egregious abuse of the patent process, that would solve it. Those two
and also negotiating, if they can negotiate, they should have negotiating power, right?
That's right, negotiating power. And I think in the end, this should be, the drug companies should have an incentive to do R&D and to do other types of innovation. Although, as I said earlier, most of it's done by smaller companies that they then purchase. But we should tie the price of drugs, as is done in other countries, to one of two things. Either its efficacy. You come up with a drug that's going to save millions of lives, you should be entitled to make a lot of money on it because you just did a really good social good. Or you tie it to the cost of R&D. You invest a lot of money in developing something on behalf of the American public. That's a risk, and you should be rewarded for it. Neither of those two things exist today. There is no relationship either between efficacy of the drug, a drug that extends life by 7 days or 2 weeks, can cost hundreds of thousands of dollars, and drugs for which there is zero R&D invested because it's already been developed by someone else. Again, prices can be set at almost any level as long as the market has been monopolized.
So that I think it has to become from you need to be in the policy level, explaining to the policymakers. That's in Congress. Second, I want to do let's go to the next step. Health plans. Health plans are. I used to be part of the small HMO networks, and I used to help them to manage the HMO networks. I learned from Prime Care, Dr. Reddy, and other plans in Atlanta. I did a run around these plans. It came with the good intentions, HMOs and all those things, but along the way, they just not producing the results the healthcare deserves and patients deserves. One is their HMOs kind of passing the risk to doctors and patients rather than the health plans, at least passing the risk to. Tell me your idea about the health plans, how and what are the challenges with them to fix the healthcare system, and and your traditional, what is the solution for that?
So the overall health plan, not just specific to medications. I'm a big believer in the idea of incentives. You know, Charlie Munger said, "Tell me your incentives, and I'll tell you the outcomes you go and you get." Have incentives that reward volume, you're going to get more volume. So you've got to shift your incentives. So the first thing is we need to move from a fee-for-service system to a capitated system, a single payment made to doctors and hospitals to take care of a population of patients with the opportunity to financially benefit when they can keep people healthier. If there's one statistic that I think is so important that everyone understand relative to the US healthcare system, it's the following. If we could control chronic disease, as you know, chronic disease is an epidemic, whether it's diabetes or whichever problem you want to look at. If we could control it as well as the best organizations in the United States today, not perfectly, just as good as the best ones are doing, we would avoid 30 to 50% of heart attacks, strokes, cancers, and kidney failures. Think about that. What would happen if we did that? Now, as soon as you capitate, now you create every incentive to do just that. You do best when the patient stays healthy. You do best when you avoid the complication of the chronic disease by better management. You do best through prevention. Everything aligns what the patient wants, because I don't want to get a heart attack. I don't want you to save my life. I want you to avoid it in the first place.
Yeah.
What the payer wants, because the costs go down and people are healthier. And yet what we see is that the insurance companies don't do it. I think they don't do it for two reasons. First of all, it's tough. It's hard to do. Organizations that are capitated take many years to figure out all the systems. You need excellent leadership. There's a lot of pieces that go into it. And number two, the insurers are doing fine today. And so despite all of the, I'll say, displeasure of the public with what they do, with the high costs, with the fact of the prior authorizations, with the narrow networks, all the things that people don't like, they still see it easier and safer to continue doing what they're doing. But this is where it ties into the medication side of the conversation. It's interesting that of the three largest PBMs, two of them are owned by health plans. You have Optum, owned by United.
Caremark.
Well, Caremark's owned by CVS, so it's owned by a drugstore, but not independent of that. And Express Scripts is owned by Cigna. So now you have strange incentives, because if they can charge a lot, they can make a lot, and the patient is going to be paying co-payments out of pocket off of the retail cost, not the final cost, the net cost after the rebates all happen. So you have a very, I'll say, complex, opaque, and inefficient system where what should happen, maximizing the quality outcomes, the access, and lowering the cost for the patient, is not the highest priority. It's not the basis of competition.
It's not a antitrust law as a health plan. Health plans and the PBMs together, they become a cohort. It's like a controlling the cost of the system. That must be a kind of a gray kind of a rules there, and how they allow that. They take a waiver from a. I mean, that's kind of a. Tell me a little bit. I don't want to say negative things. You can. You are very good at that.
So think about it this way. Let's think about a drug that costs $1,000, but it only costs $100 to manufacture. So what does the drug company say? I will give it to your PBM for $1,000, but I'll also give you a rebate for $400. So your net is $600. What happens for the insurance company? It just made $400 selling this drug, a lot more than they would have made if they actually had to improve the operational efficiency. That's where the strange part is. The patient, on the other hand, has to pay the deductibles off of the $1,000. The payer has to pay the $1,000. Who are the winners? The drug company, it just made $600 on a $100 manufacturing cost. And the insurer, who just made $400, basically for doing nothing except putting that drug into its formulary or putting that drug into the local pharmacies with whom it contracts.
No, I wanted to go back to this misaligned incentives. You said that, but let us talk about the health plans in general. What would you change in the health plan? Because yeah, what would you change the fundamental things in the health plans itself? When they're giving health savings account, whatever the insurance, do we need actually health plans? Is a risk assessment now with the new AI? Do you think we can replace all the insurance companies and produce a computer system that can do the risk analysis better, and we don't need insurance companies anymore?
I think we could get past insurance companies, but it's a lot of steps down the line. And for most business people, I mean, you own a manufacturing plant, you make some parts for cars or whatever you might be doing in your company. Now you've got to provide insurance to your people. It's not your expertise is engineering. And now you got to figure healthcare out. You got to do contracting. It's a very complex process that's there. What do I think is the first step? We should force companies to sell products that are capitated. That will be the piece that now aligns it. And capitated not at the insurance level like it is today, capitated at the delivery system level, the doctor and the hospital. So they both do better when the patient does better. It increases patient safety, increases prevention, disease management, everything aligns. And from my viewpoint as a patient, not just a provider, I like the idea that my doctors have incentives to keep me healthy, to avoid making a mistake, to not having me spend extra time in a hospital, to allow me to get better faster, and most importantly, right now, to invest in generative AI. I'm a big believer that if we're going to make these changes in making quality go up, access easier, and costs come down, generative AI is the tool to do it. And why do I believe that? Clinicians work really hard. But if I see you every 4 months, how much can I do to improve your health? Yeah, I can measure something and make an adjustment. If you get acutely ill, I can see you in the office. But you have a problem, let's take diabetes. A third of Americans have either diabetes or pre-diabetes. You need that managed every day. And that's what generative AI can do.
No,
Lower heart attack, strokes, cancers, and kidney failures, 30 to 50%. You've just saved $1.8 trillion. You've lengthened life expectancy, which, by the way, is no higher now than it was in 2010. You've improved people's health because the added years are going to be good years, not bad years. Everything is great, except the companies that today are making money on it, who would find themselves making potentially less money in the future.
Dr. Pearl, General Motors, for example, their car, they thought the same way. We produce cars, we don't care about healthcare costs. But eventually, what was the biggest lesson was their healthcare costs exceeded more than their steel. It just doesn't make any sense. So they need to understand what the healthcare system. They need to put more resources for that kind of a process. And what's going on is not. We cannot dissociate. Okay, yeah, I don't know anything about health plans. I think benefit managers can do a little bit more action and more on educational things, and then they can be involved in the price dynamics itself. What do you think?
Well, let's just look at the numbers. The United States spends $14,000 per American on health, American person on healthcare. Switzerland spends 10,000. Germany spends 9,000. Every other nation spends less than half. And if you look at the 12 most industrialized nations, we're talking about Great Britain and France and places like that, we are last in life expectancy. We have the highest maternal mortality rate. We have the worst childhood mortality rates that's out there. Portugal spends 1/5 of the United States with better outcomes as measured by independent groups like the Commonwealth Fund. What we have today is as you said at the start of the program tonight, a completely broken system. There's so much more that we can do. We mentioned the PBMs having 3 of them having 70% market control. When you look at the distribution of drugs, 3 companies have 90%. What is that? What is their incentive? Is it going to be to control the market and raise prices, or is it going to become more efficient and lower costs? They're going to just control the marketplace. We are looking at a system that we call capitalistic, but it's not. It's monopoly.
It's not. Yeah. No, now let us talk about the biggest controversial, and you spoke with Mark Cuban, pharmacy benefit managers. General public don't even know. It took me a long time to even know they exist, to be honest with you. PBMs are like 3 of them or 4 of the major ones, I don't know what those people are, but even still I'm learning what those people are. Optimum there, that these are the 3 or 4. Cardinal Health, probably one of them, McKesson. So, AB Spurgeon, like a Carson or something, that is another one, AB Spurgeon. These are the PBMs. I was trying to understand, Dr. Perel. It is a complex than a quantum physics, complex than a differential equations. The flowchart, I saw that. I lost my mind. I could not understand what that loops are. The negative loops, negative feedback loops, positive feedback loops. It's a system. If you put in the physics system, it is a total failure. Nothing is flowing, It's flowing one way.
It is complex, but it's actually very simple. So you have someone's making the drug. Those are the manufacturers. We know their names. That's Lilly and Roche and companies like that. Someone has to distribute the drug. Those are the McKessons, the Amerisource, and the Cardinals.
They're wholesalers.
Those are the distributors. They take it from the manufacturer to the pharmacy, or from the manufacturer to the doctor's office, or the manufacturer to the hospital. And then you have who decides what drugs are going to be covered by insurance. That's the PBMs. Who negotiates with the manufacturers? That's the PBM. As I say, 3 of them have 80% of the market, and they're all associated with another entity with mixed incentives. The drug company, CVS, they like to have higher prices because they make more money. And United owning Optum and Cigna owning Express Script, they have the rebates currently. So this is the crisscrossing where the people responsible, the people guarding the chicken house, actually have the greatest incentives to let call it the wolves in. These people are going to make the most money when they actually allow prices to rise. Sometimes, by the way, they'll encourage a brand drug over a generic, even though they're exactly the same chemically, because the rebates will be better. And now, the people in the drug world are very smart people. It's not hard for them to figure out how to use a broken incentive system to reward the wrong behavior. As I told you earlier, I have a drug that I should price at about $150, 50% profit margin. I actually say I want to sell it for $600, but I price it at $1,000. Now I create a cascade. I give the rebate to the PBM. The PBM puts it on the pharmacy. The patient and the payer pay $1,000. I keep $400. You keep $600. Everyone winks. But that's what's going on in medicine today. The PBMs don't make any sense. And this is where Mark Cuban, he starts a company called Cost Plus, which basically says we're going to take the lowest price we can get this drug for. And that includes the rebate, everything else. We're going to negotiate as hard as we can.
Is he
We're gonna
negotiating with the drug
add-
manufacturer? Is he
What's that?
negotiating with the drug manufacturers directly?
Yes. He's
You tell
negotiating
me
with
his model. I didn't understand his model. Please
He's
explain his
negotiating
model.
with the drug manufacturers, and whatever the price is, if they give him a rebate, then that comes off the price. Whatever his price is, now he adds a small percent. I don't know if it's 5% or 10% or whatever, and that's what you get. It's right there in front of you. It's fully visible. What's his problem? His problem is the drug companies don't like it. Why
No,
don't they
don't
like
like
it?
That's my question.
The deal I told you before, where they can sell it for $1,000, but get the PBM to make it the #1 drug on the pharmacy list, as opposed to someplace else where the $600 drug's competing with a $400 drug. Now they don't have as good an agreement. So the challenge is getting the broken industry to go to a more logical system of care. But it's a very good approach to it. And there are other places too, by the way. GoodRx is another example. DirectRx is another good example of organizations doing the same thing, buying it at a good price, selling it at a good price. And this is the battle going on inside the industry. It's also why the drugs that are no longer under patent, they actually, in the United States, become much more competitive with the rest of the world because there's competition. But the ones under patent, that's where the monopoly is. And as that patent gets extended from 9 years to 13 years to, in some cases, 20 years because of all the legal pieces, now you have prices of drugs that have gone up year over year over year, twice the rate of overall inflation.
I never imagined Mark Cuban to be David and the drug companies are Goliath. He's already a billionaire. I thought, well, everybody, but he's facing bigger than him, a bigger money, a bigger thing. Is challenging all these drug companies. What is your discussion about with him? How is he fighting those big David and Goliath fight?
Well, he's a big guy. He owned the Dallas Mavericks, and he's on Shark Tank, and he's a pretty wealthy type of guy. So at some point in your life, some of us decide that we just want to make the world a better place, and if we can make a reasonable income at the same time, that's a really good thing to happen. So I think he's just not greedy. And if you ask me one word that defines what's going on in American medicine today, I'd say it's greed. Now, again, I want to be very clear for listeners and viewers. Some people don't have that opportunity. Clinicians in general are struggling. I want to be clear about that. But when we're looking at the drug industry, we're looking at some of the hospital industry, we're looking at the insurance world, I think these publicly traded companies are simply trying to maximize the profit regardless of the impact it's going to have. I can't find very many examples where they've said, well, we could charge more, but we're not going to. I think that's a little bit of what Mark's trying to do. He's trying to say, I can charge more, but I'm not going to. And that will be my business model. And I'll have a reasonable profit, but not an exorbitant one.
So there is kind of a competing with the wholesalers and a whole like a distributor, right? Is a kind of a contributing. Is trying to compete with the McKesson and those people, right? And the McKesson and Cardinal Health. Those are people he's trying to compete. So let us talk about a little bit about this drug. We went through a little bit. So what do you think is drug? These are big ones like a McKesson or these people, I don't want to name them, but these are wholesale or distributors. What could be, I want your solutions, what are the things we need to do, solve this problem? So what are the things that they're doing wrong and what we can do about it?
Well, again, I think whenever you have a relative monopoly, and as I said, 3 of them, we're talking about the McKessons, we're talking about the Amerisource, we're talking about Cardinals. Those 3 have 90% market share. I don't care what industry you're in. When you have a huge industry with a limited competition, you're going to be paying a lot more money. than if you actually had some type of true competition going into place. If it's a small industry, 3 can sometimes work because it's a small industry. But you're talking about, drugs are now close to 20% of total spend, and total spend is now approaching $6 trillion. So you're talking about over $1 trillion in the end of all the different parts of that process. It's just ripe with the opportunity to use monopolistic power to raise prices, not on behalf of patients, but simply on behalf of your shareholders. Now, you can argue, well, that's the job of a company. I mean, there are companies that do it. The problem is when you're talking about healthcare, you're talking about the equivalent of, electricity and gas in the winter. If we allowed companies to raise the price of gas and electric in the winter, I guarantee it'd be twice as high. And if you live in a place with a lot of snow, you'd have no choice but to be able to pay that price. And that's why we have limitations on it. And we do not have any of those limitations inside the healthcare world.
But there is a big problem, Dr. Perel, about these wholesalers. One time, we are very, I see I'm a foreigner. I came from a small village in India. One thing I saw that here is very stunning to me is that the American public, the assault by these companies to the American public individuals, and then is a systemic problem. They make it as an individual responsibility. These drug companies, they were facing up trials right now. These wholesalers about the opioids, the drugs they push it to the market, and they say, oh, that's systemic. They're drug abusers. We can't hide them. 50% of them are drug tested positive. How can we, innocent Americans, they are victims here? You just to push them as a patients, or they are the culprits. That's what bothers me in that sense. A systemic problem, non-transparent. There's opaque, and then at the end blame the patient. It is not pristine system there.
I concur with you. I think that, there are some patients who were drug seeking, but we know that a lot of patients became drug addicted because of prescriptions. We know that there was quite a number of physicians who made a lot of money writing the prescriptions. In any system of the size of healthcare, it's not a single actor. It has to have a continuum of actors that are there. And so when you start with high drug prices, you now have the ability to negotiate deals that don't benefit the patient, but benefit someone else. And that may be the PBM, or maybe the distributor, or maybe the pharmacy. So at every point along the way, excuse me. And in the opioid world, you also had the problem of just doctors who recognized, oh, I could write 100 prescriptions or 200 prescriptions. It wasn't very many of them, but they could create tremendous damage because they could create a volume that met a need that in this case was an addiction once the people were on the drugs. What's also interesting to me is a lot of people went into heroin, and by heroin extension fentanyl, because it was cheaper than the drugs they had to buy. That's so interesting to me. The drivers of that change. I just don't. I'm someone who thinks well of people. I don't think they're bad people doing any of these things. When the incentives are misaligned, when the systems are broken, problems are going to happen. Yeah. And in this particular situation, when monopolies can be achieved easily, prices can be driven up, compensation can go way up, you're going to see that. And over time, what you're seeing is shrinking and shrinking and shrinking. The number of half of communities in the United States don't have hospital competition. Prices go up. Hospitals acquire doctors' practices. Now they have a monopoly of cardiologists or urologists, oncologists. Guess what happens? Prices go up. Every place we're looking, seeing the same phenomenon in American medicine, And here's the thing that so many people don't recognize. They assume the problem is the insurance company. They assume that the cost is borne by their employer because they get provided health care. But no, what ends up happening is that as an executive, as a CEO, in your mind, benefits, meaning healthcare coverage, plus salary is a constant. If this year you made 7% more money and you can give out 6% more salary and benefits, and 5% go to benefits, you can only give out 1% salary. If it's 3, you can give out 3. If it's only 1, you can give out 5. That is what people are missing. And we've seen wages stagnate across the United States for a couple of decades. And we're seeing today over half of Americans cannot afford the deductible if they got sick. The only reason they're okay is they don't get sick, so they don't use all of the deductible. Half of this nation, we are sitting on a powder keg, and it's going to go off very soon. Probably still the same numbers I did. Healthcare premiums and costs this year up 9%. The average employer is spending $27,000 every year for a family of 4. That's like giving every worker a new car every year or a Mercedes every other year. It's just not, it's going to erode the competitiveness of our country. The challenges created by medicine extend way beyond medicine. And if you follow
the patients,
it's going to get worse, not better.
the end of the totem pole is the pharmacist. Then all the people go to the patients, go there and they blame patient, even though we are not using pharmacists are well-educated people. We are not using them, their education, their expertise. Just they became a pill, counting the pills. It's like a machine. So what are do you need with these unnecessary layers that we exist? Maybe we don't. I'm not sure your opinion on that one. What do you think about that? If they are just counting the pills, it doesn't make any sense. We are wasting their additional layer of expenses.
I have tremendous respect for pharmacists, and in the hospitals where I've worked, if you have a bleeding issue, you're on a drug, Coumadin is a classic one, that makes your blood not coagulate well. There's a level on which if it does too much, you bleed, and too little, you clot when you don't want to clot. So you want to hit that sweet Goldilocks spot. That is now being done almost only by pharmacists. And guess what? The results are better when pharmacists do it than when doctors do it. Why is that? Because they're completely trained on the medications. They know exactly what to do. And so I agree with you in a lot of different areas. But one of the things that to me is going to be very interesting is the state of Utah has now made it legal for a generative AI tool to prescribe a drug to a patient with a chronic disease, to monitor it. Because these are just algorithmic approaches. And so I think pharmacists could do it very well. I think generative AI is likely to do it into the future. We are at a point where we're going to see a major disruption in American healthcare, where we're going to have all these opportunities to raise quality and lower costs, and we're going to have tremendous resistance. By the way, we're seeing the same thing across every industry. So medicine is not going to be unique, but it also will not be unique. It will be
I'll come back to the technology. I'll come back to the technology, your favorite subject. But the last one I'm talking about in the totem pole is a patient, is a victim. One Chinese company wants to hire in Texas some labor force. 50% of the labor force tested positive for the drugs. That's what they said. When there is such a number, it is not an individual. There is a systemic problem. America has to wake up. This is a systemic problem. Somebody dumping them. And then we have a romance scams, tech scams. We are just unrelenting. I don't know how that works, Dr. Perel. American public is subjected to tremendous assault, individuals, by all these indirect players. is technology is sometimes positive, as you say. Let us talk about, before I go to technology, let us talk about patient. What do you think of patient is a victim, and also what is the responsibility should we do? We are making suffering normalization, normalizing this suffering. That should not be normalized. We need to, this is a doctors need to raise their voice and talk about, this is not a measurement. Something is wrong here in the system. A patient, at the end of the day, suffering should not be normalized. What is your opinion on this patient responsibility wise?
Well, as I've said all along, I'm very supportive of the physicians. I'm very supportive of pharmacists. I'm very supportive of nurses. I'm very supportive of patients. So that's where my allegiance lies. And right now, the patient is paying a major problem. They're paying a major problem because they can't get care that they need. They can't get the diseases well controlled. They're paying too much for the health care they receive and the outcomes that are accomplished, and they are relatively powerless. It's why in my book, ChatGPT MD, how AI-empowered patients and doctors, I started with patients, can take back control of American medicine. I think that's a big opportunity that I'm actually very excited about, that possibility. I'm not blind to the risks, but I think that opportunity to empower the patient, but the laws and the regulations have to change in parallel in a good way. And I think people are often trying to create roadblocks to stop the progress in order to preserve what they have today, whether that's the revenue, whether that's the profit, the income, or some cases, just the jobs.
Dr. Perel, I met you the first time when you released the book Mistreated in the Commonwealth Club. That's Commonwealth Club. So after that now you wrote the Chat GPT. What did that big shift? What do you think changed it from that book to this Chat GPT? What did this technology played role? Just give me some your rundown. Your what are the things from the mistreated to Chat GPT? Your progression of your thinking.
So as you point out, I've written 3 books. The first one, Mistreated, was about the broken healthcare system. The second one, about uncaring, was about the broken culture. And in both books, I basically have recommended all along certain changes. Care should be integrated, clinicians working collaboratively. They should be using modern technology. They should be getting paid on a capitated basis based on the quality of the outcomes. Pay for value, not pay for volume. And it needs leadership. But in both of my first 2 books, before ChatGPT came out, the challenge was, how can they accomplish it? And this is where I really like what you just said to me about the patient, because I believe patients don't want to be sick. They want to get better. We haven't had the tools to help them. Eat better. What does eat better mean? I don't make enough money. I come from a background, you're from India, and you want to eat certain foods that are different than what the person in the next house does, who's from Japan, and that's different than the next person who's from Mexico. Everyone has their own preferences. Well, ChatGPT or any of the generative tools, Gemini or Claude from Anthropic, any of those tools are capable of helping you. You want to exercise. Well, we tend to think about exercise as going to a track and working out. Well, people work. Well, no, there are things you can do in your house. You don't need to buy a fancy machine or heavy weights to do it. So there's all these things that we can now do to empower you. You have a chronic disease, a hypertension. How are you doing? You got to wait till you see the doctor 3 months from now. No, you can get a blood pressure cuff. You can put all the data into it, and it can do a first and second derivative of how it's going. So finally, we had this ability to be able to support clinicians who want to do it, to be able to empower their patients, who want to better control chronic disease, to be able to accomplish it, being able to interpret data at home. And so that has been the big shift. In my book, ChatGPT MD, I talk about how when Gutenberg invented the printing press, people thought it would just be maybe printing some Bibles. Where are we now today? We have a world in which the majority of people are literate. Back then, it was less than 1%, just the very, very elite. We have universities. Imagine a university if we didn't have any books. How could you teach? So this is where things happen. You know, when the internet came along, we didn't imagine we'd have things delivered to our house within 24 hours, almost anything we wanted, a list of 10 million products you could get delivered to your house. But that's where we are today. People are underestimating what these generative AI tools can do because they are simply so new, and they're doubling in power every year. 5 years from now, they're going to be 32 times more powerful. And by that point, they will, I believe that for most patients and most problems, they will be as good as clinicians and potentially have fewer misdiagnoses. Right now, most misdiagnoses kill 400,000 Americans a year, another 400,000 chronically disabled. I think the technology could be better. In the same way that people writing about self-driving cars point out that the mortality rate on a per mile basis is about 1/10 as much in a self-driving car than it is in a human driver. As human beings, we can't accept that, but that's what the data says today.
You know, Dr. Pearl, the technology changed so much. I use extensively all the LLMs, ChatGPT, LLM, Gemini. I use all of them. But even they became very smart in a lot of ways. From a hallucinations sort of gone down. Became a fan. But there is one, even they are suggesting, even the LLMs are suggesting, there is something science is missing here. So what I did was I created a model, invariance model. What invariance is? It just to take a human, non-negotiating human principles. Nobody should die on the street. For example, that's just giving an example. If you create a moral boundaries on all of them, what are the things that we can accept that human, how do they not suffering, and then build the mathematical structure. It's not just an abstract aspect. Mathematical structures, you do that. The methodology should not be paradoxically conflicting each other. You cannot create some paradoxes so they should not be conflicting with the principles itself. Then the third one is the technology. So AI can force multiply the good things. AI also can force multiply bad things. If the system is not clean, AI cannot support the AI force multiplier. It multiplies everything, good and bad. So I think one of the things is we need to change the fundamental principles of that invariant. What are the human principles? You don't need a loss. When you stop the constraints, if you cannot build a casino and tell them not, if anybody plays there, I will put you in jail. It doesn't make any sense. You build the casino and tell them anybody walks in, they're going to go to jail. So it is not make sense. So I think we need to have United Healthcare CEO said that anybody with the right mind should not design this kind of a healthcare system. We are doing all the patchworks. So what do you think, besides all these patchworks and is technology, in my view, even technology is suggesting that even LLM is telling me that you should not start with the technology. You should start with that fundamental principles if you wanted to fix the healthcare system. I created a MedBricks predictor system, how the human care capacity. I wrote a mathematics to it, and the platform I developed it. I don't know, So I put the Kaiser Permanente. I put all the insurance companies in the model. For you, congratulations to you. You should be proud of it. Kaiser Permanente came number one on the invariance principle, how that came out. And then Kaiser Permanente, Mr. Lawrence Hamilton was on my podcast. I was telling him, is the Kaiser Permanente came number one. Then they came in Geisinger in Pennsylvania. The last one is a fee-for-service was the worst model, it said. My invariance model that it said. So my question to you is a scientific principle. You give me your final philosophy. what are the things that policy level and the scientific principles that, even if I don't forget about all the policies, forget about the regulations, can we create a mathematical principle, a scientific principles that really helps the patients at the end of the day, and unbelievable cost structures and burdens on them, and this assault on the American public by healthcare system.
Well, you recently saw that both OpenAI, that makes ChatGPT, and Anthropic, that makes Claude, have now created a health tool inside its large language model. This is a massive advance. Up to this point, no one has been willing to do that. Yeah, they did it for exercise and sleep and things like that, but no one was willing to do it in terms of response to medical questions. According to OpenAI, 40 million people every day are accessing ChatGPT to ask medical questions. This is happening. So using your model and your mathematical model, which I love, by the way, this idea of creating an ethical system inside of a mathematical model, here's what I would say. Number one, we need to build into these tools a confidence level. The tools can tell us, are you 95% confident, 80%, 60, or 40?
Yeah.
It's not 100%. And we should expect doctors to do the same. I'm not quite sure what you have. I think there's about a 20% chance you might have cancer. Well, I'm pretty sure what you have a 95% chance of having cancer. You're going to treat those two numbers very differently. So that's the first thing I think that we could do. And as I say, I want to see it both with the technology and with the humans. Number two, if you actually look at what I think will be the next generation of these tools, it's going to be taking a large language model, then you distill out of it those aspects that relate to healthcare. You don't need to know about Grecian urns, and you don't need to know about a whole variety of things that are not in medicine. It's only a certain percentage of that. And then we train it. You train it off of data from nurses or pharmacists giving advice in advice centers or chronic disease management programs. You train it off of doctor-patient interactions. So now it's better than the LLM because it's focused on a specific area, healthcare interactions. And then we don't approve it until we've tested it. How do you test it? You take a set of patients who are calling, let's say, an advice center, and you have them speak to an LLM that's been trained. They know that they can't be sure which it's going to be. You have a human being overseeing it all to make sure nothing goes wrong. And you see how good the advice is as judged by other people who don't know whether the answer came from a human or a machine. And when the machines are 10% better than the humans, we certify them.
Yeah.
Now what we can say is we've proven that it's going to be better. It may not be perfect, but it'll have a more reliable, consistently accurate way to go. And those two steps alone, tell me the probability and test it against humans. If both of those exist accurately, we can measure the first, we can measure the second. Now I think we just make it a tool of care delivery. Now it creates a whole lot of other problems because people in jobs, like in every other industry, and what do we do if it's wrong, and who gets sued? So we have a lot of issues to address. But I think those are the two, using your system of ethics and evaluation and mathematics. Those are the two things that I'd recommend we do if we want to have this be a tool that is more for the good than the current alternatives that exist.
Thank you, sir. Always talking. Great pleasure to talk with you all the times. It is you shed a light on so many things. You have a broad spectrum of understanding of the healthcare system. We need the highest policy level. I think people like you make a small. Keep talking. Is people like me get educated and get inspired. Actually, that's why I create these models. If you hang on, for a few minutes after the podcast, and I will talk with you. But one second. Thank you so much. It is an honor and privilege to have you. It's always welcome your MedBricks podcast. You are a valuable asset. I always promote you in my intro, everything. Thank you for so much. Your contributions to healthcare is immeasurable in my view. Thank you, sir. Welcome to the MedBricks webcast. And I hope you like my. What is your opinion of my podcast I've been doing last 2 years? You've been attending.
Your podcast is fabulous. You've done a tremendous amount of education. You've brought in a broad group of people. And I think you have a wonderful way, along with your co-host, Susan, of being able to make it clear to your audience. When it's not clear, you make sure that people clarify and that they understand what's being said. And for anyone who wants more information on what I said tonight, they can go to my website, robertpearlmd.com, where they can find a lot of information. And I've actually just started a short form video where I'll be actually taking on, it's called Controversies in Healthcare,
Nice.
Controversies in Medicine, to take on the things that you're always asking about how to solve controversial areas. And I look forward to getting your feedback and others about that particular video.
Thank you, sir. Good night. Good night, all of you.
Good night.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it